Bowler classification. Okay, the same surgeon who did the Bowler angle of the calcaneus, he classified the spine. He was the first one to classify.
Okay.
Okay.
We have always
Online conference.
So we will, in the overview, we will discuss thoracolumbospinal injuries, cervical fractures, classifications, description, management decision process, and treatment and approaches. So the controversy is there is no single universally accepted classification system and don't predict outcome of treatment in all cases. So Satish, are you there?
Sir.
What is this?
This is, sir, 3-column classification of the spine that includes anterior column, middle column, and posterior column.
Okay. So who described this? You know the surgeon name?
I don't know, sir.
Dennis. Okay. So
Dennis.
yes. So in the anterior column, it comes the anterior longitudinal ligament, anterior annulus, anterior 2/3 of vertebral body. Middle column, posterior 1/3 of vertebral body, posterior annulus, posterior ligament, ligament. And posterior column consists of pedicle, facets, lamina, spinous process, and posterior ligaments. So Satish, if there is single column involvement, it will be stable or unstable spine?
Sir, when middle column is involved, spine is unstable.
Okay. And if the only anterior column is involved?
It can be stable or it can be unstable, sir.
Okay. If only one column is involved, the spine is stable. Okay. When the two columns are involved, anterior and middle are involved, you have to further look into it by MRI to find the posterior ligament injury. Okay. And if all the three are involved, the spine is unstable. You understand? For example, they show you X-ray, for example, having anterior, middle, and posterior column involved, you will say the spine is unstable. But if the anterior middle column is involved, you will say I will further investigate it by assessing the posterior longitudinal ligament and posterior column by doing MRI. Okay, and then I will decide. So one is stable, 2 column is you have to look for any other pathology, and 3 is always unstable. Did you understood this?
Yes, sir.
But there is one problem in this. This is a descriptive classification. If you see this spine, someone calls you and tell you that there are 3-column injury from the ER, you will not think of this amount of injury. Look at the cord. It is compressed. It's compromised spine. Posterior longitudinal ligament is involved, and there is a dislocation. You can see this. This is a spinal transaction, and easily you can identify that this is also 3-column injury. So by saying this is a 3-column injury, it cannot give you any information. It cannot help you to decide what type of surgery you will do, what type of intervention you need, and when you need. And it does not assess neurology also. See this. This is a complete spinal cord cross-section. You can see that the vertebrae are not aligned. The vertebral column is not aligned. The spinal cord is transected, probably at the level of T4, T6, T4 to T6, and this is also 3-column injury. So what happens is that Dennis is a very simplistic classification system. It gives the fracture patterns unaddressed. There is no clinical parameters or neurology and no idea which approach to do. Ali Muhammad is with us. Ali Muhammad is with us or no? I think we cannot hear it. Okay, Mohsen?
Sir.
I want to ask you something, simple question. This is a classification system, okay? And it has type A, B, C, and type A1, A2, A3, B1, B2, B3, C1, C2, C3. You can see it.
Yes.
What do you think?
Yes.
What type of classification system is this one? What is this called?
This is probably an AO classification.
Yes, it's the AO classification. So this is a descriptive sort of classification. We don't use in exam, we don't use it clinical, but it is only done for research purposes.
Right.
Okay? In exam purposes, you can divide into three types. A is compression, B is destruction, C is rotation, and C1, C2, C3
Right.
with the severity of injury. Okay. There are some explanations in the AO website which can tell you which columns are unstable, which are stable, but we don't use it normally.
Right.
So it's based on AO spine classification system is based on two-column concept of Nicole and Holsworth, similar to the one of thoracolumbar injuries. Three types based on the fundamental injury patterns. A is vertebral decompression, B is destruction, C is rotation. Each type has three groups with three subgroups. Isolated spinous, transverse process fractures are not included. Type B and C injuries are the dominating cervical spine injuries. The severity in terms of instability of the injury as well as the rate of neurological deficit does not continuously increase from A to C in the cervical spine as it does in thoracolumbar injuries. So it's more acceptable in thoracolumbar region than cervical spine. We have someone named Javedullah Khan. Javed?
Yes, sir.
What is this TLICS? Do you have any classification by this name?
Sorry, sir.
Yeah.
Thoracolumbar
Yes.
injury severity score.
Yeah. It's called thoracolumbar injury classification system. Do you know
Yes,
do you know its components?
It's the type of fracture
Yes.
and the ligaments, involvement of the ligament,
Yeah.
and I guess involvement of the spine, maybe
Neurology.
spinal cord.
Neurology.
Mhm.
It has three components. This is the most
Yes.
important classification system. You have to remember this. For example, you have any trauma patient coming in exam, you should classify that patient into thoracolumbar injury classification system. There are three independent predictors. First is morphology of the fracture. Second is integrity of the posterior longitudinal complex. The third is neurological status. Okay.
We also had one university question.
So, Mohsen, can I ask you some question? If you see this,
Sure.
you can see my arrow.
Yes. Yes.
Why complete is given 2 and incomplete is given 3 points?
Complete is 2.
Yes. Incomplete is 3 points. Why? Okay. This helps you to identify the urgency of intervention. Incomplete injuries, if you do intervene, they will be stabilized and they will improve. Complete cord compressions, there are less chances to improve the neurology. So,
Right.
incomplete is given 3 points and complete cord injury is given 2 points.
Right.
So, it's the most accepted approach, okay? And it helps you to identify whether to go anterior or posterior or combined, okay? If you have
Right.
anywhere the neurological posterior longitudinal ligament involved, then you can go posteriorly to fix the fracture. Okay, I will. Abid, you are there?
Yes, sir.
Yeah.
Yes, sir.
This, tell me what is the benefit of anterior approach or pros and cons of anterior approach. What do you think? In abdomen.
Yes, sir. We have to dissect more in the anterior approach,
Okay.
but we can gain more stability over the anterior side.
Okay. What else? What else?
Uh,
The disc is,
Placement of graft.
you can easily do decompression at the disc
yes, sir.
level
Yes, sir. Yes.
of anterior approach. What is the benefit
Easy
of
to place
posterior?
graft.
Easy to place graft, easy to do the sagittal balance. What about posterior approach then?
No particular idea.
Okay.
Neurovascular structures are safe because we are not playing with them.
Yes, but anterior approach there is directed canal decompression. Okay. We can restore sagittal anatomy more easily. There is a minimal loss of motion of segments. Actually, who is this? Okay. So actually I have a problem. Okay, minimal loss of motion of segments, avoid posterior musculature and poor respiratory functions. In the posterior approach, excuse me, Abid,
Yes, sir.
your mic has some problem. It's giving us a noise.
Yes, sir.
Yeah. Okay.
Okay, sir. I am changing it again. Okay.
The posterior approach is familiar for most of the surgeons. It avoids viscera, avoid major vessels. It's beneficial for high thoracic and low thoracic regions and high wound breakdown, especially cervical. Actually, I cannot continue. You are there? You are all are here or no?
Sir,
Yes.
yes, sir, we are here.
Yeah, there is some problem in the system. I think someone has mic is continuously giving me a reverberation. I can hear my voices now.
Yes,
So
sir, me too. I was in. सर सारे माइक्स टर्न ऑफ कर दें फिर क्वेश्चन आंसर का छोटा सा सेशन रख के ना उसमें करते हैं.
Okay.
Audio is not so clear today, sir.
So you intermittently turn off your audios. When you want to speak, you just turn it on.
I will mute all of them. Okay, so posterior approach, the good thing about it is that the spinal surgeons are mostly familiar with posterior approach. It avoids viscera, it avoids major vessels. It's more effective in high thoracic and low thoracic regions, but there is a high risk of breakdown, especially cervical regions. Cervical spine, mostly if you approach posteriorly, there is a very high risk of breakdown, and some papers have given it more than 7 to 8% risk breakdown. Still, there is. Okay. There is still a problem. So Abid, you can hear me, Abid?
Yes, sir. I can hear you.
Yes. Do you know what is the benefit of anterior approach in transperitoneal approach? Do you know how to do it? Yes. Okay. It's reserved for the. Actually, Abid, your mic has a big.
Sir, someone else's mic is causing problem. I have early on switched off and the same voices were coming.
So you kindly request everyone to turn off their mics. Might that help?
I am turning off my mic.
No, no, this is not Abid now. This is
Everybody should turn off their mics because that might be causing problems. So
I don't know what to do.
So whoever you want to ask a question, he can turn on his mic and then answer.
Okay, so anterior approach is reserved for fusing L1, L5 to S1, and it's the only important. You have to mobilize the great vessels for it, and you need to take help of general surgeons. So who will tell me the anterior approach? Okay, in anterior approach, basically we use the radiolucent table like Jacksonian table. Okay. Abdul Rauf,
Yes, yes, sir.
you know what is anterior approach?
No, sir, I had just joined, so I don't have any
Okay.
idea about.
In the lumbar spine, how we do anterior approach, I will make you understand. Okay. Normally,
Right, sir.
we place the patient on a radiolucent flat Jacksonian table. Okay, with the Treadle-Berg position. Okay, Treadle-Berg position,
Right,
so
sir.
abdominal fat is flat. We put a
Right,
bag in
sir.
the sacrum. C-arm is on the right side. We give a perimedian anterior incision, 3 to 4 centimeters lateral to midline of left side. Okay.
Right, sir.
जनरल सर्जन इंसिजन देते हैं उस तरह पेरिमीडियन इंसिजन देते हैं ठीक है
Right, sir. Right,
उसके
sir.
बाद rectus fascia transversalis fascia and then we reach the retroperitoneal face okay peritoneum को हम retract करते हैं ठीक है blunt
Right,
dissection
right.
and we reach the
Right,
psoas
sir.
okay after reaching the psoas we identify the iliac artery vein lumbar artery mid-sacral arteries and we reach the vertebra. When we reach the vertebra we identify it with a disc and then we do the procedure which is needed.
Right, sir.
So it's very simple. Okay, I will repeat it again. We place the patient supine in the slight Treadle-Berg. Abdul Rauf, you are new over
Right,
here.
sir. Yes, sir.
I'm telling you, you keep on moving.
Yes, sir. Yes, sir. Yes, sir.
I will remove you. Okay.
Right, sir. I'm with you, sir. I'm with you.
Yeah, because when you are moving around, I'm hearing something else. You are moving around the pages or something. Okay, you should use headphones instead. Okay, so
Right,
normally
sir.
in anterior approach, you place the patient supine on a flat Jacksonian table. You put in Treadle-Berg position to avoid the fat. There is a bag under sacrum. C-arm is on the right side. You give a perimedian anterior incision over the left side, and then there comes rectus fascia, transversalis fascia, then comes the retroperitoneal space. You do the dissection of the peritoneum to one side, that is on the right side. Then you reach the psoas, do the blunt dissection over the psoas, identify the iliac artery and vein, identify the iliolumbar artery, mid-sacral arteries, identify the small vessels and ligate it, localize the disc, and then do the procedure. Okay?
Right, sir.
For the posterior approach,
Sir, sir, do we see the major blood vascular structures in this anterior approach?
yes, definitely. I'm telling you, you see iliac artery, vein, iliolumbar artery, mid-sacral arteries, you see all the vessels. Okay?
I'm talking about aorta, sir.
Aorta is on the left side, boss. It will easily identify it. You will see it for sure.
Right.
Okay. For the posterior approach on the lumbar side, you put a Jacksonian table. Someone out of all of you have ever did a thoracic spine surgery or lumbar spine surgery posterior approach?
No, sir. I don't have any experience.
Anyone has?
Sir, I have seen one case of
Okay.
posterior spinal fusion, sir.
Okay. So what you do is you put in posterior prone position. Okay. You do neuromuscular monitoring. You see arm is perpendicular to the table. Okay. You identify. You take a K wire. You position it and find the level. Mark the level. Okay.
Okay.
Then you give a midline incision. You reach the spinous process. Then you do pop dissection. Expose the transverse process. Then you identify the lamina subperiosteally, cranial to caudal. Okay. Then you expose the facet joints. Then you do laminectomy. How you do laminectomy? First you bar down the lamina, make it thinner, and then with the carousel roundels you remove the lamina. Okay.
Okay, sir.
Okay. Actually, you don't know the posterior approach and anterior approach, so I will not discuss about XILF. Basically, this approach is a lateral approach. Okay. The problem with this approach is that it is on the lateral position. You can easily reach the spine, but the problem is there is high risk of sympathetic chain injury, genitofemoral nerve injuries, segmental arteries injuries, and ureter injury. The problem is sympathetic chain. There is high risk of sympathetic chain in XILF than all others. Otherwise, this is a very direct procedure. Okay, the patient is positioned 45-degree lateral. Okay, and the lateral incision is given. Mostly we go from the left side instead of right side.
Sir, why on the left side, not on the right side, sir?
There is a story behind it. Actually, vena cava is more risk of injury than the aorta. That's the reason. You understood?
Right.
Yes.
Yeah, right.
Even aorta is more resilient to injury than the inferior vena cava. Okay, Satish, what do you think? What is happening here?
Sir.
X-ray on the right side, your right side. There is an X-ray lateral view of thoracolumbar spine.
Right.
Okay. Do you find anything over here?
Yes, sir. I can see a fracture at L3 vertebral body, sir.
Okay. Where is the fracture?
There is a compression fracture
Okay.
at a body of L3 vertebra, sir.
What do you think? What else is in this X-ray? There is something else also in this X-ray.
Can I tell, sir?
Do you see? Okay, Mohsen, you
Small
tell.
element.
Pars interarticularis disruption.
Yeah, there is a.
So I can see the.
Yeah, actually, when Mohsen told you, now everyone can see it, really, because there is a distraction over here in the pars interarticularis.
This is AO type B sort of fracture with distraction of the posterior elements along with the anterior compression fracture of L3.
Okay.
So it's an
Very
unstable in the spine injury basically.
It's an unstable spine injury. How you?
Shehbaz here.
Yeah. How? What further you have to do it for this week? What do you think?
Yes, Shehbaz knows more of a spine than all of us.
Yeah, good that he is fine. So what you do for this patient is you will do MRI. Okay. There is an anterior.
So in MRI you.
Yeah, I cannot hear you. For such patients, okay. This, for example, this fracture comes in your exam. You will discuss the anterior part of the vertebral body, posterior part of vertebral body. You can see it's more lengthened than the L3. Okay. Then is distraction in the pars interarticularis. So there is a compression and distraction force on the posterior aspect. So you do MRI for this patient.
Sir, I have question. Sir. Regarding MRI and CT scan. This is a bony injury, so why not CT scan?
You have already identified everything. You have to do CT scan also if there is actually, for example, if there is a bony injury, CT scan is better. But for PLIC,
Right,
posterior longitudinal ligament, you have to do MRI for at the impulse. This patient will need both MRI and CT scan both in this case.
Right, sir. Right, sir. Clear, sir.
What is
Thank
this
you.
injury called, by the way?
What, sir?
What is this injury called?
Compression fracture.
This is flexion distraction injury.
So what is
This
called?
is flexion this section injury.
Whiplash.
No, there is no whiplash. Whiplash is in cervical spine. Have you heard about chance?
This is flexion
Yes,
distraction.
yes.
This is a
The
chance.
chance
Chance
fracture.
in cervical also.
No, there is no chance. We will discuss it. Leave it for now. This is a chance fracture. What is other relative injuries with chance fracture? What do you think?
Burst.
Something in viscera, abdominal injuries, duodenal perforations. What is the mechanism of this?
Are acceleration, deceleration.
Yeah, this can happen with this. What do you think? What is other thing is what is the mechanism of injury of this? You know, seat belt injuries. This is a mechanism, one of a common mechanism. You can see this patient is. Oh my God, today is a bad day. Okay, Mohsin, can you hear me?
Yes, sir. I can.
Yes, sir.
Yeah, actually, there is a big problem now today. Okay, this is a chance injury. So it's basically hyperflexion injury, lap belt injuries, transverse fractures to the vertebral body, 50% associated with intra-abdominal organ injuries, and posterior column disruption. Okay. So if you do MRI for this patient, this is the MRI of that patient. If you see the injury mechanism, the vertebral body has been divided into half even. There is a chip fracture proximally. The spinal cord is involved. There is posteriorly high density at T2, which evident that there is a posterior ligamentous injury also in this patient. So what are modifiers? Does anybody know what is a modifier? He can unmute his mic and tell me what is modifier.
So modifier basically anything which can affect your study results or anything, any factor.
Okay, for example, I have a T12 wedge fracture. Okay, Sebas, I have a T12 wedge fracture. I have decided to treat it conservatively. What are the factors which will affect managing that patient conservatively?
Progressive neurological
It is AO type 1 fracture. That is only the compression fracture of the vertebral body. Then you have to assess the posterior corner injuries because these are the ligamentous injuries and they make spine unstable. So you have to address these injuries also.
Okay. What else?
Are you asking about the conservative versus operative
I am planning to do conservative management for T12 compression fracture, which is less than 10% of the, or 20-30% of the vertebral body. What are the factors which modifies? Those are called modifiers. For example, patient-related factors, multiple injuries, sternal fractures, rib fractures, burns. Okay,
associated
injuries, which changes my plan of management for conservative management. So these are ankylosing spondylitis, dish.
Excuse me, sir.
Yeah.
So is this the term modifier specific for spine or something else?
Yes. In spine injuries, if they ask you what are modifiers in spine injury, you have to tell them what are the factors which are not associated with the fracture, but the decision is changed with the management. These things are associated with the patient. For example, multiple rib fractures, sternal fracture, pre-existing ankylosing spondylitis, dish, multiple rib fractures, coronal plane deformity, and burns. Okay, you cannot put a brace in a sternal fracture patient. You cannot put multiple rib fracture into brace also. So these will need operative intervention instead of conservative. So who will tell me if there is a fracture, how you decide what level you fix, how many levels you decide to fix, above, below?
Stable vertebra.
No, this is not scoliosis. Every vertebra is stable. Every vertebra above the fracture is stable.
So depends ke what level injury you have. If you have got thoracolumbar junction injury, you have to go for short segment fixation only, because by fixing the short segment, you will just fuse the spine and limit the mobility of that patient. So
Okay.
if you have got injury in thoracic or lumbar level, then one level above and one level below is sufficient nowadays.
For example, Shehbaz, I'm doing thoracolumbar fixation level T12. Okay. You will go how many levels below and how many levels above? What do you think?
So if I'm at thoracolumbar junction, one level above, one level below, that would be sufficient. If there is no other chance fracture or any posterior lateral corner injury,
Okay.
posterior corner injury.
Your spine is unstable at thoracolumbar T12, and you want to go either above or below the fracture. What will you prefer, above or below?
So on both the sides, basically, one level above, one level below.
No, for example, you decide to have more extensive fixation. I want to do either 2 levels above the fracture or 2 levels below the fracture. Which will you prefer?
Above is better because that's more stable than the lower one.
Above is better. Why above is better?
Yes.
You are right.
Because
Above is better.
thoracic spine is not much of a it does not give much of a mobility as compared to the lumbar.
Okay, so why don't we
So
stop
the fixation will be stable. Fixation will be much stable as compared to the lumbar. If we go more levels down,
it is a bit different. What do you think? Where the screw cutout or failure will happen?
Yes.
Implant will fail.
Yes.
Level, lumbar or thoracic? Proximally will fail or distally will fail?
distally must fail.
No. Actually, if you see the thoracic spine, it is kyphotic. Okay.
Right.
Okay. Every implant is stable in tension, in compression, in compression, then tension. Okay.
Right.
So a kyphotic spine. So normally there is kyphosis in the thoracic spine. So if I fix the thoracic spine will feel before lumbar spine. Okay.
Yes.
So normally we have intuition, or we normally fix thoracic spine more than the lumbar spine. Second thing is this, that we want to improve the mobility. We don't want to fix the lumbar spine more extensively, which will stop the mobility of the patient.
Right.
So normally we fix thoracic spine. We are inclined to fix more of thoracic spine than the lumbar spine. If there is a T12 fracture, if I need to go above, I will go to T10. And I know T10 is the pedicle are thin. There is a problem, but I will not go down to L1 and L2, L3 because it will reduce the motion segment. So thoracic pull out, more chance. Okay, thoracic is more stiffer. Lumbar inclusion, more loss of motion, and pedicle screw at the fracture site is possible. So if I fracture site, I can put a pedicle screw, then I don't need to fix above and below. Like I need to fix above, one level above, one level below, but I need to not to go 2 levels above. Did you get it? Did you understood this?
So it's better to fix level above.
In thoracic region, yes. It's better to fix one level above, 2 levels above. Like instead of 1, if you need one more level, get it 2. Otherwise, Shehbaz is right. 1 level above the fracture side, 1 level below the fracture side is enough most of the times. Most of the times. Not
so
always.
The picture is 1 level below, and if you want more levels, 2 levels above.
2 levels above in thoracolumbar junction. The story regarding thoracolumbar junction. Otherwise, in thoracic spine, there is no problem. Either go above or below. What disease is this? If you see this, do you remember bamboo spine?
Yes.
Yeah, this is typical bamboo spine. So
This is
why?
fracture dislocation in a patient with ankylosing spondylitis, basically.
Yeah. So what, like, if you have a patient of ankylosing spondylitis, why you prefer to fix it, or you will go for conservative? What do you think?
As you have early on told us, the modifies ankylosing spondylitis, and so we will go for fixation.
Okay,
operative
Abid,
and-
okay, you got for
Yeah.
fixation. You will do more levels or less levels than normal spine?
More levels
Why?
as compared to
Why?
sir, because it is more fixed, and so we will have to get the more stability at the fixation side.
So yes, it's okay. But there is any orthopedic terminology for this?
Sir, the spine above and below behave as a one unit. That's why we should take more.
Yeah.
Rigid fixation.
Yeah, there is an orthopedic terminology. There are long lever arms. They are acting as long, rigid lever arms.
Okay.
So that's why
the
we need
long-
to fix longer. I should have a construct which is longer than conventional one. Okay.
Right.
It is again in correspondence. You can see the structure, and we need to operate on it instead of making conservative. Okay. Zahid, what is this? Can you describe this structure? Okay, leave it. Zahid, what is the mechanism of this structure? Simple question. Compression, distraction, rotation, axial loading. What is the mechanism?
This is a burst fracture, basically axial compression.
Okay, good. Axial loading. So, how will you describe a burst fracture?
So the burst fracture is a fracture of the compression fracture of the vertebral body.
By the height, sir.
So it's comprising major portion of the vertebral body.
Okay.
With retrobulgation of the fragment into the spinal canal.
Okay. So,
Or
there is a compression, there is a segmental depression, there is or segmental kyphosis and retropulsion. Shehbaz is right. This word retropulsion, you have to document. Like, for example, you're doing telephonic conversation, you can tell that like there is segmental kyphosis, or there is a sagittal imbalance at the level, there is retropulsion, there is a segmental depression. These are the words you should remove.
is it necessary that it's always a retropulsion, because can't it go to mediolateral or anteriorly?
So you
Can the
have
fragments go?
So you have to comment it that there is or there is no retropulsion. This exam is a must. This fracture comes to you.
But in this we don't have a retropulsion.
This you have retropulsion. What is this then?
There is retropulsion. That is a fragment which Dr. Alamdev is pointing out.
This is CT scan. Actually, on MRI, if you see, there is a huge edema and everything over here. So remember this word retropulsion.
Right.
So you explain the vertebral fracture.
So anything coming into the canal, into the spinal canal, is retropulsion.
Yes. Explain the vertebral fracture. You explain the retropulsion. You discuss the sagittal profile, and you discuss the posterior elements in burst fracture. Okay.
Right.
You see, this is a burst fracture, giving an example that how it affects. Okay. Who will tell me what is this? It's written over there on the it's written on the picture. Can someone read it?
This is basically minimally invasive sort of surgery where you pass pedicle screws through these drill holes, small holes, and then you slide the rods along them.
Not rods.
This is sort of minimally invasive percutaneous pedicle screw
pedicle
fixation.
What is the benefit, Shehbaz? What is the benefit? Why we do it? Like, there should be some reason to do this. हम ऑर्थोपेडिक में मिनिमली इन्वेसिव क्यों करते हैं? वैसे कोई बता दे मुझे. वही आंसर.
Soft
tissue protection.
soft tissue
Yes. What
to minimize blood loss, to
Yeah.
minimize blood loss,
Yes. Early recovery.
Early recovery, less pain,
Yeah.
early
less
discharge.
hospital stay, less hospital.
Yes. So these, these are the words. In exams, they say what is the benefit of percutaneous fixation or minimal invasive fixation. So you can give this answer very easily. It is a minimal invasive procedure. Okay. It reduces the blood loss. Early ambulation is possible. Early discharge, recovery, soft tissue injury is less. Okay. Normally, how we do it, we normally under C-arm, we put a K-wire on the pedicle screw on the lateral aspect. For the right side, it should be 3 o'clock. On the left side, it is 9 o'clock. Okay. And we start laterally and move medially to the pedicle screw level. Okay. And they will not ask you anything else. Actually, I asked you this question already. So the benefit, less blood loss, no different in outcome at 5 years, and reduced admission duration. And if you see, this is what Shahbaz explained, that with the you put a pedicle screw and do the fixation. So we discussed cervical spine. The cervical spine incidence is around 2%, and there is a neurological injury. Subaxial spine involvement is very common. Classification is difficult, and previous classification didn't have any consideration for neurology and only considered for mechanism alone. Okay. Whenever you have a spinal cord, the cervical spine X-ray, you have to explain this. These are the 3 lines: anterior vertebral line, posterior vertebral line, and spinal lamellar line. If they ask you if there is any dislocation, retropulsion, if there is any subluxation, not retropulsion, subluxation, you have to draw these lines in exam. Okay, and normally make it a practice to draw these lines. Okay, you know about these lines or no?
Yes.
Yeah. Okay.
Yes, we do.
Okay. So cervical spine injury was basically classified by Allen Ferguson. This is the flexion compression, vertebral compression, flexion distraction. Extension compression, extension distraction, lateral flexion. Okay. Probably they will not ask you. Only they will ask you about the mechanism of injury alone. Otherwise, they will not ask any question regarding this. Okay. If you have a cervical spine injury, you have to classify it according to SLIC, subaxial injury classification system. It is based on the thoracolumbar injury classification. So who can tell me, Satish, can you tell me what are the components? Satish.
Sorry, sir.
No, we discussed TLICS. What were the components at that time?
Fracture type, neurology, and
yeah, fracture type, neurology, and
ligaments.
Ligaments. Okay. So, can someone tell me what is the difference between the cervical spine injuries and components? What are the differences? What is the difference? Single important difference.
Cervical spine injury can cause quadriplegia if the lumbar spine.
Regarding the mechanism. Satish, I think this problem again. This. I cannot block this. There is 2, 3 Satish, but the lower one, I don't know who is he. But I cannot even mute him, and I cannot even block him. And it's his voice. Okay. In cervical spine injury, there is more chance of disco-ligamentous injuries without fractures. Okay. There is high risk of disco-ligamentous injuries. In cervical spine injury, there is more. We are more. There is someone's child crying. Can you stop him?
This is a bit disturbing, sir.
Satish?
Sir, this is not me, sir. Somebody else. Maybe a second Satish one.
Which one is Satish then? Okay, I found it.
Now seems better.
Yeah, I block all Satish. Then he can, the one who is the real Satish can. Okay, so cervical spine injury has more chance of disco-ligamentous injury without any fracture.
I thought the chairs are with you.
I found it. Okay, now you can hear me?
Yes, sir.
Yes,
Yeah.
you can.
It's clear now.
Okay. It's not clear. Okay, so more chance of disco-ligamentous injury in cervical spine. So Slic system is put together by the Spine Trauma Study Group, and the score is based on thoracolumbar injury classification system and severity score. The three major injury characteristics are injury morphology, like the fracture, disco-ligamentous complex, and neurological status. Additional minor criteria is injury level, anatomical osseous injury, and injury confounders. So this is the Slic system, almost similar to the TLICS system. And you have to remember this in exam. The significance is the same. Less than 4, you have non-operative. 4 operative versus non-operative, you decide, and more than 5 operative treatment. So in exam, for example, if someone asks you, these scores give you only an idea, okay? And you have to decide the patient specifically. You have to decide regarding the patient intervention, not only on Slic system but other factors as well. Okay, what is this? Can someone tell me?
Cervical collar.
Hard
Philadelphia
cervical
collar.
It's a
Philadelphia collar.
Okay, yes.
Philadelphia collar.
Yes, I heard this. Okay, so it's a Philadelphia collar. What is this then?
This is
Milwaukee.
CTLS.
CTLS.
You have not seen CTLSO. This means you have not.
No, CTS.
You have not seen CTLSO. This is called SOMI. Okay, it's called sterno-occipital mandibular immobilization brace. If any brace which has a sternal cover, occipit support, and a mandibular support, it's called SOMI. Okay.
Sternomandibular.
Yes, sterno-occipital mandibular immobilization brace. Okay. This can come in spotter. That's why I put it here.
Right.
What is this? It's called 4-poster post. If you see, there are 4 posts: 1, 2, 3, 4. 2 anterior, 2 posterior. Okay. In this, there is no posterior support. Here, there is posterior support. Okay.
Right.
Then what is this?
Hellos.
Yeah, halo. By the way, it's called invasive halo because there are pins in it. Then what is this called?
Non-invasive halo.
Oh, very good. You are learner. You are learning very fast. So it's called non-invasive halo. Okay. So who will tell me the benefits of posterior approach? Any idea?
So in posterior approach as compared to anterior approach, you have to you can avoid the neurovascular planes as you identify in the anterior approach, and also
what neurovascular planes you see in anterior approach? There is nothing in anterior approach. Regarding the posterior approach, yes, there are. You cannot do discectomy. You have to.
The laryngeal, recurrent laryngeal nerve.
Okay.
recurrent.
Okay. What else?
And also there is less tissue dissection required in posterior approach as compared to anterior approach.
This is also not true. There is more dissection in posterior approach than anterior approach. You do some periosteal dissection, which is far more than anterior approach. Okay, these are the fine. Posterior approach is familiarity. Okay, biomechanically it is strong. We are talking about cervical spine. It can help in direct decompression. High union rate and wound healing is an issue. The problem is with the wound healing, and the biggest problem is pain. This and this. These are the biggest problems. That's why we don't do posterior cervical approach in most of it. Yes, you have to do it when there are posterior injury, but normally we try to avoid it. So who will describe me anterior approach? This is the most common approach. It can come in exam. Someone knows or no? Or I will start it.
Shahbaz.
Shahbaz, do you know anterior approach? I think Shahbaz is left. Shahbaz is left. Okay, let me start it. Okay. First of all, you do level check, okay, with the C-arm, okay. Then you give a transverse incision, okay, extending obliquely from the midline to posterior aspect of the sternocleidomastoid. Then you dissect the skin, then the fascia, then the platysma. Then you identify anterior border of sternocleidomastoid. Then you retract sternocleidomastoid laterally. Okay. Then you find the strap muscles. You retract it medially. Then you check the carotid pulsations. Then you retract the carotid sheath laterally. Then you cut the pretracheal fascia. Then you localize inferior and superior thyroid arteries and tie off it if necessary. Then you reach the longissimus coli, and then you can dissect the prevertebral fascia, retract the longissimus coli, identify the level by the needle, and start the procedure. Okay? Are you there?
Yes, sir.
Okay. The problem, what are the complications which can happen with anterior approach? Recurrent laryngeal nerve. Okay.
Yes, sir. Recurrent laryngeal nerve injury, vascular injuries.
Fistula formation.
Yes.
Fistula. Yes.
What else? The sympathetic chain is on the longest coli.
Yes.
It has a risk
Yes, sir, yes.
of Horner syndrome also. And retropharyngeal hematoma and esophageal injury, tracheal injuries. This can happen. By the way, which side of recurrent laryngeal nerve injury is more common, right or left?
Left.
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 Who said this?
Sir, I said this.
If I say right, then
Sir, on
I remember it's the same. Sorry, I was off. I think discussing complications of the
injury
anterior approach.
chances are almost equal, but which was more prone, right or left?
I think the right is more prone.
Right is more prone, but why? It has a variable course.
Because basically when you go through the pretracheal fascia, so it runs alongside the trachea.
Yes.
So when you are dissecting the pretracheal fascia, you can injure it easily.
Yes.
And again, it is variable, so it has not the constant root, right?
Yes. So there is one question when we are doing dissection. What are the strap muscles are crossing C5 and C6 level? Which of the strap muscle comes across C5 and C6?
Sir, omohyoid.
Yes, it is omohyoid. Okay, you remember it because this can come in exam. What is the benefit of anterior approach?
Sir, basically, yes, sir.
Yeah, tell me 1, 2, 3, 4. Don't say basically. You are quoting basically too much. Okay, tell me. Yeah. Don't laugh. Okay. What do you think? What
So
are the benefits?
if you want to do corpectomy, so you can go anteriorly. If you want to fuse the anterior vertebral body, so you can put in a graft and fuse the spine. So
No.
basically, whenever you
What are the benefits?
The less pain, post-operative pain.
Yeah, this is like fine. What else? You avoid prone position. Okay. You can do direct decompression of the disc. Okay.
you can do anterior fusion,
Yes.
ADCF sort of.
Definitely. What else? Yes, I think your answer is right. You can do so. You maintain the sagittal balance more efficiently by anterior approach. The same answer which Sebas said. It means the same. That you can do easily ACDF and avoid too much fixation, too more level of fixation, and can maintain a sagittal balance quite easily.
I just left for a few minutes. What we discussed anterior and posterior approaches.
Yeah, we discuss anterior approach only. So we avoid prone posture.
Okay.
We do direct decompression. We maintain the sagittal balance. Okay. What do you think? What has happened here? What type of cervical injury is this?
This is not cervical.
This is not cervical, but actually I
This
put
is
a
not
post.
cervical.
If this was in cervical region, what will you suspect? How will you describe it? Same. This is a burst fracture, and you have to describe it with axial compression, retropulsion, and high suspicion of posterior ligament injury. This is not cervical for sure.
This type B sort of fracture.
What is this?
This is anterior carpectomy followed by a fusion with titanium cage along with the plate anteriorly.
Along with the plate. What else you can place it? What
you can place ribs. You can place ribs. You can place fibular stud graft. You can use substitutes. Like
so what is this then?
Combined anterior posterior fusion.
Yes, but what is
combined one? Exactly.
What is this in between?
This is fibula.
Yeah, this is a fibular graft. Okay, very good. So what option you have after corpectomy? What do you think?
So corpectomy, after corpectomy, you have a space. You can fill it with the titanium cages. You can have fibular graft. You can have ribs taken from the and you can have substitute, bone substitute.
No, the cage is right.
You can put autograft, allograft, you can put whatever you like. So you can put autograft, allograft cages, which can be polyethylene, titanium, expandable, or with screw fixation. Okay. So normally, as I told you, cervical spine injuries can happen without a fracture, and their high cervical spine injuries has more the ligamentous injuries, so we have low suspicion, low threshold to do MRI for such patients. So remember this, that this is very important. So for further investigations, we always have a low threshold for cervical spine injury. There are strong ligaments from occiput to C2, and sometimes the cervical spine injury can be missed very easily. And here we are showing the transverse ligament, other ligament, and apical ligaments. We need to learn this anatomy at least. Take a good diagram from any book and just remember those. Okay. Same. So who will tell me what is What type of image is this, by the way? It is a MRI or CT scan?
So this is CT scan.
Okay. What view is this? Sagittal or coronal?
The coronal view of the spine CT scan.
What are the findings, by the way? What do you see?
Sir,
So,
the fracture of the second vertebra of the just below the dens.
Okay. What do you think? It's stable or unstable?
Sir, it's unstable.
Why it's unstable?
So there is approximately more than 2 millimeter distraction.
If I say there is no distraction, this is only the image which is showing it like this, and it's undisplaced. How you classify a fracture? How you consider a stable and unstable fracture? In orthopedics, in general, not in this case. Normally, how you classify the fracture is unstable.
If the fracture goes back to its
in general,
yes,
not in this fracture. Just
if after reduction does not maintain its the reduction is not maintained, it goes back to the yes, that's an unstable fracture.
Okay. Second, anything else?
Ligaments.
Ligaments injury can make a fracture stable or unstable.
So if the stabilizers, soft tissue stabilizers around the fracture fragment, if they are injured, then it is
torn.
Now tell me, will this fracture have a ligamentous injury?
Yes, of course.
No.
No or yes? Okay. Patella fracture can have quadricep injury. Patella fracture can have quadricep injury together. Possible?
It's rare because
it's very rare.
Patella,
yeah.
Very rare because patella is fractured, so quadricep won't.
Okay. So do you think
retinaculum ruptured?
Okay. So in this fracture, ligaments will be probably intact. Okay.
They are usually attached to the dens.
Okay. Yeah. And the other good thing about this fracture is that the subsurface for the fracture is huge.
Mm-hmm.
So do you think it will heal or not heal?
Yes, it can heal.
It can heal. So what type of fracture is this? Do you know any classification? 1, 2, 3, 4, 5, 6, or what? Any idea? How odontite fracture are classified? This is odontite fracture.
Tip avulsion and at the base, and then involving the body.
So this is type 3.
Type 3.
So type 3 are stable. Type 3 are mostly stable, not unstable. And you can immobilize it and it will heal. What about this? What is happening in this CT scan?
So coronal image CT scan showing the fracture at the base of the neck.
Yes. What type is this one?
Type 2.
It is stable or unstable? It will unite or not unite? Simple question.
It's difficult. It will not unite.
Why?
Because less contact area and
no, more important.
Probably.
First, you have to say something else.
Due to
ligamentous
vascular supply, basically.
Yeah.
It is both high and
this is called watershed zone, and it has low blood supply. That's why it will go into non-union. Okay. So these are the classification of tight fracture. Type 1, which is a fracture of the upper part of the odontite peg, and it's there and potentially unstable. Can happen that it become unstable. I think this is a bit. Mostly they are stable. Yeah. Type 2 are the one which are unstable and have high risk of non-union. And type 3 are through the odontite to the lateral mass of C2, best prognosis for healing. Okay.
okay.
So in exam they will give you this X-ray and ask you what is your comment. So for the type 2, you should always say it is a watershed zone, the more chance of non-union. If it's undisplaced, I will treat it conservatively, but more chances that it goes to non-union. Old patients, the problem is that there is high risk of death and other complications with the halo. So I will do it Philadelphia collar. In young age, I will use it. I will use halo for such type 2 fractures. So what is this C2 fracture? So you can manage this different way, halo or a screw. This is a non-invasive halo, and non-invasive halo in a retired fracture is almost equivalent to invasive halo. Okay, so this is one of the options which you can use. What's happening here? This is the lateral view of cervical spine. What's positive? Shahbaz, what is this?
Fracture disruption of the pars intra-articularis.
Excellent.
And
which level?
C1, 2, 3, 3, 4, 3, 4, C1, C3, 4.
2. C2.
C2, 3?
C1. This is 2.
Right, right.
So what fracture? This is, it's a bilateral pars fracture. There is any name for this fracture?
The hangman fracture.
Very nice. So it's called hangman fracture, and you can manage it in many ways, multiple ways. Most of the times it is you need to have operative intervention, but sometimes you can avoid it. Multiple fractures are indicated. This is the same hangman fracture. Actually, let me explain something. Hangman fracture is classified by a classification called Levin classification. I don't know about the exact details. You can read it, but less than 3 mm, and it classifies into less than 3 mm, more than 3 mm, and some angulation. And you can do multiple type of fixation like fusion or sublaminar wires, or you can do the transarticular screws, or C1 lateral mass screw fixation and C2 screw pedicle screw fixation, which is best results. What is in between these two black arrows? Can someone describe this X-ray for me? What are these arrows indicating?
The arrow is the AD, the anterior.
Yeah, no, Atlantodense.
Atlantodense interval, ADI.
Okay, this is essentially, what is the significance of this Atlantodense interval? Any idea?
It designates the instability.
Yes. Between what?
Between the atlas and the axis.
Very good. So how much millimeter is
designates the narrowing of the canal.
Yes, but how much is how much it should be? ADI. How much ADI should be there?
7 mm is, I guess,
7 mm is too much, by the way.
Three, maybe 3 or 4.
3 or 4. 4 mm is gone. More than 4 mm, you suspect transverse ligament.
Less than 3 is critical.
More than 4 mm, transverse ligament is ruptured. More than 6
right.
mm, more than 4 mm, transverse ligament is suspected to rupture. More than 6 mm, sure transverse ligament is disrupted. And you have to always do flexion and extension. Okay. So in exam scenarios, they can ask you what is this arrow indicating, and you have to describe ADI. What is ADI? So remember the words 4 mm. So 4 mm, more than 4 mm might be a transverse ligament rupture. More than 6 mm, surely the transverse ligament is disrupted. And always do flexion extension views. Actually, these are common in C1, C2 instability is most common in rheumatoid arthritis. But in that, this distance is not 4 mm. I think it's more than 4 mm, but you have to do operative intervention is more than 10 mm. So this again showing the AABI. You can read it also. What is this then? What is this called? It's called power ratio. Can someone tell me what is power ratio? It's written over here, by the way.
It's basically the ratio of from the distance from the basion, that is the occiput.
Okay.
The base of the occiput.
Yeah.
To the
okay.
Yes. To the posterior arch.
Yes.
Of the first cervical vertebra.
Okay. Actually, you can see this ratio over here. It's from the tip of the dens to opisthon divided by basion to the posterior respective arch of C1.
These lines also have particular names.
Yeah, but what is the significance of this? If it's more than one,
so it designates subluxation.
Yes. So it designates C1, C2 subluxation. Signifies anterior subluxation described as BC divided by OA. BC is distance from basion to the mid-vertical portion of posterior laminar line of atlas. OA is opisthon to mid-vertical portion of posterior surface of anterior ring of atlas. If more than one signifies anterior subluxation. Most of the old examiners would like to ask you this. So what is this? What is this distance between which two components is this distance?
Between the basion and basion and the tip of the dens.
Yeah, base of the skull to
base of the skull
to the odontoid.
To the odontoid, yes.
Yeah. So if this distance is increased, what do you think? What will happen?
This will narrow the canal, the cervical canal.
No. It's C2 distance from C2 to the skull. What can be?
Distraction.
Yeah, distraction. What is it called? Occipitocervical injury. It represents occipitocervical injury. The normal distance is 12 mm. Okay, it's very easy to remember and it's very easy to draw it even. So it's called basion dense interval, and more than 12 mm in adults is significant. So someone told me chance fracture in the cervical spine. Who said this? Someone said chance fracture in cervical spine. What is this?
Yes. Yeah, it's an avulsion, a chance fracture.
What do you think? What is this? Like, can you describe this X-ray? Okay, what type of mechanism of injury of this fracture? Like, how this happened? What do you think? Flexion, extension, axial loading?
Flexion injury.
Flexion?
Flexion distraction.
How come? If flexion and distracted, it should have injured somewhere else. ऊपर वाला जो है ना fracture होना चाहिए था. ये तो नीचे वाला fracture है ना? If it had to distract,
this is just an extension injury.
Extension में तो posterior injury होनी चाहिए थी.
Posterior होनी चाहिए थी.
हाँ. यहाँ तो यह fracture avulsed fracture है. Like it is flexion compression injury. Flexion compression. The C3 is pushed into C4 and small avulsion fracture. What do you think? ये high energy fracture है, low energy fracture? What do you think?
A low energy.
Ligament injury is low energy or high energy? This avulsion, ligament avulsion is high energy.
Ligament avulsion is a low energy.
No.
It's a high energy.
Because
high energy.
This is a high energy. This is a flexion compression injury. A small piece has been displaced. If you think about the
but less of a destruction.
Huh?
Less of a destruction if it's a high energy injury.
Yeah, this is the most notorious and most missed fracture in cervical spine. It is a very dangerous situation. So, for example, this is a high cervical injury. C3 has been forced into C4. Okay. So, what do you suspect if this is flexion compression injury? What else can injure this? What else can injure here? By arrow, you can see it. What else can injure here?
Sir, posterior longitudinal ligament.
Posterior
Yes.
ligament.
The posterior ligaments will be distracted. Okay. What is this usually called, by the way? It's not called chance, by the way.
Okay.
It's called flexion.
Teardrop.
Yeah, excellent. Flexion teardrop injury. Okay.
Okay. Okay.
And this is the most common A and E missed injuries. Okay. And mostly you have to fuse them from front as well as back. So it's a flexion teardrop injury. See the mechanism: sudden forceful flexion, diving injury. I saw one patient in my training who dived into a shallow pool, and then after he came to me in the ER walking, and he told me that I had an injury in the cervical spine. I did the X-ray and I was literally shocked because the cervical spine was completely, like the posterior elements were completely displaced, and I was jumping around. That this patient came walking, and I was with the patient, and everyone was like, literally shocked. How come he came walking? And he has normal neurology, and we had to operate him. So it's a highly unstable because of ligamentous instability. Okay.
Yes.
I will just go again to see this X-ray. Just see this X-ray and don't miss it. Okay. Because the thing is, in accident emergency and emergency, they will discharge the patient and you will see the next day the patient, and most of the time neurology is there, but you have to examine. So this is the same MRI of same patient. You see the findings. There is a involvement of the posterior longitudinal ligament anteriorly, and the spinal cord compromise even. So most severe fracture of cervical spine, extreme flexion compression forces, mostly C5, C6, unstable both bony and ligamentous. Diving into shallow pool injuries associated with neurological deficit is more common. So what are the cord syndromes? Anyone has any idea? These are the most easiest things. Someone has to answer this.
Yes, cord syndromes.
Yeah.
There are different types of cord syndromes.
Yes.
Like a bronze cord syndrome.
No.
Central cord syndrome.
No. First say complete or incomplete cord syndrome. Complete or cord injury can be complete, incomplete. Then incomplete,
Yes,
the most common. What is the most
can be
common?
hemisection, bronze cord.
Bronze cord is the rarest. Who will tell me what is the most common cord injuries?
Central cord.
Yes, central cord. So you start with central cord. What is common in central cord? Like clinically, what is the neurological deficit?
The lower limb is more affected than the upper limb.
Upper limb is more affected or lower limb is more affected? What do you think?
I think the lower limb.
In the brain, in the cord. Upper limb is represented in the center and the lower limb is represented in the outside. So upper limb is
lower limb is less.
Upper limb is more than lower limb. Okay. Upper limb is more than lower limb. Remember it. And the prognosis is good or bad. It has excellent, good prognosis. Okay. What is the mechanism of injury of cord, central cord syndrome? Hyperextension.
Hyperextension, your burst fracture.
No. Hyperextension of degenerative spine.
Hyperextension is basically.
In a degenerative spine causes.
Only the hyperextension leading. So much disturbance. I think there's continuously connecting in.
So central cord syndrome is I will So central cord syndrome, upper is more than lower extremity. And the prognosis is, in our books, the prognosis is good. Not better than Brown-Séquard quad, but it's good. So common incomplete cord injury, hyperextension injury to degenerative spine, cord injury in central gray matter, upper limb is more involved than the lower limb. So those patients in central cord injury will be able to walk at the end of it. Normally in the central cord syndrome is ASIA C, we operate them early, and ASIA D we observe and operate if indicated. Okay. But it's a controversial, intervention is always like there is a controversy around it. What is this then? This should be questioned from Shahbaz. What is this? Shahbaz is there or no? I think he left already. What is this, by the way? Mohsen?
Sir, no idea.
Okay.
They're probably mini plates. Mini plates or something?
No, they're not mini plates. Do you know, it's called, actually, it's called laminoplasty. Okay.
Okay, okay.
Central cord syndrome, there is a problem. The cord, there is already degenerative spine, and the spinal canal is narrow. Okay. So when they are decompressing it, in laminoplasty, what they do is they open up a lamina like a trap door, do the decompression, lengthen decompress the canal, okay, and then close the lamina with these fixations. This is called laminoplasty, most common in the far Asian countries like Hong Kong, Singapore. It's not common in European countries. Yeah, I still have the problem with them. So what is this anterior cord syndrome? Okay, this anterior cord syndrome is with always the vascular compromise, the vertebral artery involvement, and there is complete loss of motor, pain, and temperature below the injury, but retain proprioception and vibration. Okay, I think you have to not remember it that much, but you have to remember that anterior two-thirds cord is involved, related to vascular injury insufficiency. There is a complete motor paralysis. There is a sensory anesthesia, and there's the poor prognosis. Who will tell me what is Brown-Séquard syndrome then?
Brown-Séquard is the basically hemi section of the spinal cord.
Yes, excellent.
And it involves the sensory disruption on the one level below on the contralateral side, and a level below on the contralateral side, and the motor disturbance on the ipsilateral side.
Okay.
The corticospinal tracts involved on the ipsilateral side.
What type of
and proprioception of ipsilateral side.
Yeah, but
at the same level.
I will just read.
At the same level.
Pain and temperature is more important. Ipsilateral hemiplegia with contralateral pain and temperature sensation deficit. Okay, remember this. Hemiresection of the spine, it is rare, and there is ipsilateral hemiplegia with contralateral pain and temperature sensation loss. Yes, one level below, and it has a very good prognosis. So, can someone describe this image? How will you? Someone there or no?
Yes.
What do you think? How will you assess this patient clinically? आपके पास ये patient आया है cervical spine injury के साथ. In the ER, how will you assess the patient? Don't think about the MRI. Yes.
I will follow all the protocols of the guidelines of the ATLS with the primary resuscitative survey.
Okay.
Securing the C-spine, stabilizing the C-spine, and then primary resuscitative survey with adjunct.
Okay. Done.
And then going for the secondary survey, okay, from head to toe examination with a detailed history.
Yes. Done.
Yes.
Done. Then what?
And then further investigations, carrying out the investigations, beginning from hematological to the imaging studies.
Okay.
And in imaging, I would like to go for the plain radiographs initially, which initially would compromise for the trauma series. And then I would like to have X-ray of further X-rays of the C-spine.
Okay. In assessment, what you want to know? Assessment, how will you assess this patient?
In assessment, we will look for the movement, neurological deficit, and movement of all the limbs. And
no. Neurology. What do you assess in neurology? Not movements.
The sensations.
Yes, okay. Sensation 1. What else?
Reflexes.
And the reflexes.
Okay. What else? Motor. You will not do motor?
Yes.
Okay. What else? Reflexes.
So
what reflex? Motor come in sensations, cannot come in sensations. You do sensations, you will do motor. What else you will do? Dermatological exam.
Myotomes.
Myotome you will do. What else is remaining?
Yes.
What else is remaining? Reflexes. What are reflexes you will do? You said reflexes.
Hoffman. The
okay.
Nobilsky's reflexes, deep tendon reflexes.
You will do superficial reflexes and deep tendon reflexes.
Abdominal reflexes.
Abdominal reflexes. What is abdominal reflexes? Deep or superficial?
Superficial.
Okay. So what deep reflexes you will check?
Patellar tendon, tendon.
Lower limb and upper limb reflexes.
Yes. Okay. Okay. Listen. I will make you understand something. You cannot say Hoffman before the reflexes. You cannot say Hoffman because Hoffman or inverted radial reflex is a pathological reflex. So you have to tell him that I will examine the superficial reflex and deep reflexes.
Right.
Pathological reflexes. Okay. I will assess the motor by MRC grading. Okay. I will check the sensations by dermatomal level on dermatome. Now we ask you clinically, like we are just discussing it. This is not like your exam. After assessing the neurology, motor, sensory, how you grade it? TLCS. Okay. What else you can do? Motor grading. How you do
motor? MRC grading.
Yes, excellent. MRC grading. You need not to miss MRC grading at all. Okay. What reflexes you need to? In superficial reflexes, what reflexes are important?
Abdominal, cremasteric.
Cremasteric. What else?
Bulbocavernous.
Yes. So you should not miss it. So if this patient comes to me in the ER, I will examine him to tip to toe after doing ATLS protocol, A, B, C, D, and D, airway and stabilization cervical spine, breathing and chest, then circulation, then disability, then exposure. I will assess the neurology. In neurology, I will assess the motor functions, sensory functions, the patient reflexes, which will be superficial and deep. Superficial, I'm more concerned about bulbocavernous reflex, okay, cremasteric reflex, anal wink, okay. Then I'll go further and do the abnormal reflexes, okay. Quantify the level of the energy. Check if the patient is spinal cord in the spinal shock or no. Then I will do the dermatomal, the motor. I will assess with MRC grading. I will do the RCR charting for this patient. Okay. You understand? Are you there, or all of you are there, or no?
Yes.
Okay. So these things you have not to miss because this is spinal case. So he may ask you how you grade this clinically, spinal cord injury. So for spinal cord injury, sir, I have RCR grading. I will fill the RCR chart. Do you have anything which you can verbally communicate? So it's called Frankel grading. You know what is Frankel grading?
No.
This is Frankel grading. Frankel grading is type A is complete paralysis. Type B is sensory functions only below the level of injury. Type C is incomplete motor function below the injury. Type D is fair to good motor function below the level of injury. And E is normal. It is the reverse. E is complete paralysis and E is normal. Okay? So you have to remember this. You can be asked in exam. This is ASIA scoring system. You have to have some idea of this before going to exam. What about this? What is this? NACICS. It's called National Acute Spinal Cord Injury Survey. It was an RCT trial regarding the corticosteroid, whether we need to give corticosteroid or not to give. In European countries, they don't give corticosteroids. But in USA, America, Northern America, they give corticosteroids. Which patient corticosteroids can help? Any idea? Like
acute injuries.
Acute spinal injury within 48 hours.
I can say within 24 hours. Why not? 24 hours you can give. But which patients? Like, yes, acute injury, but what type of patients? Any idea? Yeah, I want to ask something. Patient has no neurology, no neurological deficit. He comes to the ER and has a compression fracture with retropulsion, with no retropulsion. You will give corticosteroids or no? Patient, there is no neurology. Why will you give corticosteroids? Okay. If patient has retropulsion, you will give steroids?
No.
Might be. If there is neurology, you will give. So, if you have a space-occupying lesion, you will give or no?
Yes, sir. To reduce the edema.
Yes. I will tell you a simple way to remember what are the indications. Have you done the training in neurosurgery? When there is a space-occupying lesion in the brain, acute lesion, or hematoma, they always give steroids. And they always give mannitol also. You remember it? So I have made this mind. When they ask me steroids, I tell him any space-occupying lesion, which can be retropulsion, okay, or incomplete spinal cord injury, I can administer steroids, but it is controversial. Okay, if they ask you in the exam, do you administer corticosteroids? No, we don't administer. Which patients you don't give corticosteroids? Pregnant patient we don't give, adolescents, younger patient we don't give, and firearm, gunshot wounds we don't give corticosteroids. What is the dose of corticosteroids? If the patient comes,
Sorry, sir.
There's a bolus dose and then a maintenance dose.
Yes, there is a bolus dose and a major dose. I wrote 3 hours, 8 hours. Okay, so let me make you understand. If the patient comes within 3 hours, I will give a 30 milligram per kilogram bolus dose within 1 hour or half an hour. Then I will give 5.4 milligram per kilogram in 24 hours. If the patient comes within 8 hours, I will give 30 milligram per kilogram within half an hour or 1 hour, and then 5.4 milligram per kilogram for 48 hours. Okay. In UK, they consider it that the risk is more than benefits, and in USA, in the Northern America, they administer corticosteroids. For us, it is controversial. Okay. So I will end the conclusion that always whenever you have an X-ray, you describe the fracture. Whenever you see any fracture, you always assess the posterior longitudinal ligament, like there is any posterior element in it. You assess the neurology, and neurology will and the compromise, wherever the compromise is, that will help you decide the approach. Okay.
Yes, sir.
I hope it has helped you a lot. Something like it has helped you in revising.
Yes, sir. Thank you very much.
Yes, sir.
Thank you so much, sir.
So we will stop it here. Okay.